All right, good morning. Good morning, afternoon, or evening, whenever you are tuning into this program. My name is Michael Kim. I'm one of the pediatric emergency medicine physicians at UW, American Family Children's Hospital. Just to spend like 10 seconds on my credentials, I did my training at Wisconsin Children's Hospital in Milwaukee. Did my fellowship there from 94 to 96, and I've been involved with pediatric emergency care since then. And I did spend extensive time in Milwaukee with EMS education. And I spent about 6 years of grant research efforts at Milwaukee County, specifically for pediatric pain management curriculum, which I will mention during my discussion here today. So it's a pleasure to be here for a refresher course, and I'll be spending a few more hours with you all during this time. So today I'm going to talk about pediatric pre-hospital pain management topic. However, I am going to give you a little input on another opportunity that Wisconsin EMSC, that Emergency Medical Services for Children, has developed a respiratory emergency care for children module that is online and available. As you can see, this course is through the DHS website. If you link into these websites, then you should be able to go through the very methodical. We spent about a year doing this, and then practice test also. As of now, January 13th of 2021, the DHS has not got their CEUs updated yet, so you won't be able to get credit for this. But originally it was designed to give you credit for this hour. So this respiratory module, if they can get to it, they may be able to get you the credit, but if not, you may not be able to. But this is a content that we had 50 plus hours of 2 different physicians and 5 different educators into this. So definitely something to check out. So I just wanted to give you an update on this. Okay, so this specific discussion or talk presentation is on pediatric pre-hospital pain management. I will be discussing some historical models of pediatric pain management and some of the barriers that present when managing pain in pediatric patients. And then we'll talk about some evidence-based advances and what we foresee in the future. I always start my pediatric pain management talks with this quote. As healthcare professionals, as providers, or even as parents, or even as a fellow friend or colleague, our job and our effort should be to cure sometimes and to relieve often and to often always comfort. So as advanced as medicine is, we can only cure small percentage of diseases that are out there, but we really do a better job in relieving pain, but we can do whatever we can to make sure that everybody always comfort the patients or the subjects that we're facing. So taking this motto that I've really tailored my career to really take care of patients, to comfort them at all times and to relieve their discomfort as much as possible, and then try to cure the problems that they present with as much as I can. So with this motto, I will start the discussion. All right, so we're going to start with a reference case of a 5-year-old Carla. It's a girl hanging upside down on the left here, fell off the backyard jungle gym, and she has sustained a forearm injury, as you can see. She's crying spontaneously or continuously, and she's not going to move her arm at any cost. So you are faced with the situation, and you are asked to take care of this patient. And there are a lot of things that will go into your mind as you're approaching this case, but we will going to talk about this. But before that, we're going to go way back into pre-hospital care. So if you look at the historical pre-hospital care, so this is a photo of a Civil War era where pre-hospital care providers were asked to tend to those wounded and pick them up and take them to the hospital. So in this stage of the game, there are not a lot of medications. There are not a lot of technical expertise. So therefore, basically, the concept back then was to just scoop and run, meaning GTH, TTH. You probably understand what that stands for. Get the H to the hospital. What would be the correct definition for this? So that's the old days, and as we getting into the 50s and 60s, and we became more astute with the technology and the advancement and the professional expertise of pre-hospital providers. So we started to stay at the scene and started playing with the patients to really care for them. That led to play, but you can run at the same time. So there's the trauma golden hour and the getting the patient to the destination, to the appropriate hospital. If it's a pediatric patient, getting them to the pediatric trauma centers are being focused, emphasized currently. So actually being able to take care of the patient while you're en route, and actually is sort of a combination of between scoop and run versus stay and play is in place currently. So I think the expertise and the professionalism and the knowledge of pre-hospital care providers has been exploded over the last decade or so, such that, and I 100% believe that a lot of the EMS providers are able to provide the expert medical care at the scene. There's some conditions that you can do a better job at the scene rather than at the hospital. But this play and run concept is very intriguing, and it's very effective. Just to give you a snapshot of how much pre-hospital transport that occurs, about 15 million EMS transports annually. About 20% have moderate to severe pain, and 50% of these patients who are in pain are kids. Up until 1996, there were only 6 papers in pre-hospital pain management, and since then there's been some increased number, but pre-hospital pain management has taken a big blow due to this opioid epidemic, and then that pain management itself and using medications has been significantly frowned upon at this point. However, those are all addressing chronic pains, and acute pain management should not be affected by those the significant effects of opioid abuse. So that said, we are going to address this pre-hospital acute pain management today. And then definitely the challenges and barriers are the consents and methodology in which the pre-hospital evidence has been developed thus far. So hopefully we can address this. Excuse me. In the perfect world, in this patient that we just referenced, the 5-year-old Carla, you would approach the patient and assess for circulation and sensation of the limb, then check for other injuries, make sure she doesn't have any head injuries, and the other internal organ injuries. And then patient will be assessed for pain using age-appropriate pain assessment tool, and then her pain is 8 out of 10. Patient is screaming with any attempts to splint the arm. Then you would use imagery, and you would use start an IV, and either use morphine or fentanyl intranasally if need be. And then you provide this medication. Then 5 minutes later, patient is scoring much lower pain on her pain scale. And then arm is comfortably splinted without significant discomfort. And then patient is gently placed in the rig, and a slow ride to the emergency department. And I would emphasize slow ride to the ED because, as you know, the rigs in the back are quite bumpy, and I think there needs to be a better development for shock absorbers for ambulances. And patient was reassessed prior to arriving in the emergency department. The patient is giving pain score of 2 out of 10, and then you relinquish the care to the emergency department personnel. So this is in the perfect world. This is how the pain management for a 5-year-old with a broken arm should go, according to Dr. Kim. However, this is what happens in the real world. So there are some studies that are cited here, but pre-hospital model of fractures are considered one of the most painful conditions, fractures and burns. So we use fractures as these example of pain causing entity. And if you look at the data from 2000 to 2005, adults with fractures got very, very low percentage of pre-hospital pain medications. In some studies as low as 1.8%, some studies as high as 26%. However, most of these patients, when they get to the emergency department, they do get pain medications. And what's notable is that pediatric patients, the children have significantly lower percentage of pain management compared to adults. So you get the adults 18% in one study to 91% in the emergency department, and adults 26% in the field versus 87%, and in this the highest in kids in 21% in the field versus 91% in the emergency department. So there's some significant not only difference between adults and pediatric patients, but the pre-hospital to emergency department pain management methods. We also wanted to take a look at the time in which to the first dose of pain medications in the field versus the emergency department. So if one of the studies showed that pre-hospital patient got first dose of opioids within 22 minutes of arrival. If you come to the hospital, it takes 88 minutes once you arrive to the emergency department for patients to get first dose of opioids. One study showed more than close to 2 hours till the first dose. And then the last study that Dr. Hennis and I did in Milwaukee County, which is unpublished, but in our field, the first dose of opioid was 17 minutes versus almost an hour in the emergency department. So this, what creates is that there's a delay in pain medications given not only in the field, but in the emergency department. So which means the patient will continue to have discomfort and suffer while being cared for. So we did some extensive research to really identify some of the pain management barriers. We've identified these in 3 different categories. One is a provider barrier, second is a systems barrier, and the third that we felt were critically important also are the patient barriers. So we'll go through this briefly. So, and when it comes to pain, as you all know, it is a very subjective experience, and we all are experts in pain because we've had them, we've experienced them. Therefore, we take our experience into the field. So everybody comes with assumptions and attitudes, but some of these are myths, some of these are facts. So I'm going to go through some of these with you at this point. So the quote, there is a given amount of pain for a given injury. So meaning if you have a fractured collarbone, you're going to have a pain score of 5 out of 10 for everybody. That sounds very crude, and as you know, everybody experiences pain differently. So you cannot assign a certain degree of pain for a given injury. So for an IV start, should the pain be 2 out of 10, 3 out of 10, or it could be 10 out of 10 for some people. So pain is a subjective experience. So you cannot assign a level of pain. The other concern is that children may become addicted to narcotics. As we are facing the opioid epidemic, there are significant concerns about giving narcotics, and children may become addicted. Research after research has shown in patients in acute pain crises with narcotics does not lead to opioid addictive behaviors. In fact, not providing pain medication in patients with persistent pain, acute pain, may end up having significant worse outcome. We will go into those later on. But the concerns of having patients addicted to narcotics is not a concern in acute pain management. The other thing that I hear mostly is if you give pain medication, it's a sign of weakness on the provider's part. So you're a wuss, and you are really emotionally attached to the patient, so you're going to give pain medications to make yourself feel better. And I think that's completely nothing further from the truth. If you use pain medications for patients who are in need of pain medications, that is a sign of a good clinician, utilizing your protocols and utilizing your to care, to provide comfort and to relief. They're using your expertise to provide comfort to the patient while you're transferring the patient to. So sign of weakness is never, it can't be further from the truth. Use of pain medications appropriately is a sign of a good clinician. How about this one? Newborn babies do not feel pain. And you ask yourself, do I remember being born, being my umbilical cord cut? I do not. Did I feel pain at the time? You may not remember them, but the fact that when you are being manipulated, when your heel is being pricked for newborn screening. And those of male persuasions, if you had circumcisions performed, there are cries that I've heard in my career. There's no cry that is like a cry you hear from a baby being circumcised. So I can assure you, research after research shown that babies do feel pain. And they will experience this, and they will remember that pain forward. And we'll go into some research that shows this. So newborn babies do feel pain. So don't ever think for a second they do not. And children have no memory of pain. Oh, they do. They will have memory of pain. They will have post-traumatic events, and they will have their different behaviors after a painful experience. So there's some research to show this. I'll go into this as well. But patients, kids, they may repress it, but they will remember that pain. That pain experience will impact them short-term, long-term, or maybe even forever. So having no memory of pain is not a reason not to provide pain medication or pain relief. Children metabolize opioid differently, therefore we should not be giving pain medications. To a certain extent, this is true. It's not a very solid argument. Babies up to about 2 months of age, they do metabolize opioids slightly slower than most of us, older patients. So in babies that are younger, newborn babies, they may require a little bit smaller doses of opioids. But by the virtue of this, when the patients are 6 months or older, the dosing of opioids, the dosing of pain medications are just the same as any other patients by their weight. So patients do metabolize opioids slightly differently when they're younger, less than 6 months, but should not have any other significant difference in metabolizing opioids. So the concerns of opioid toxicity or side effects should not be an issue because we have technology and the clinical skills to be able to monitor these. Pain is character building. So if you have a lot of pain, then you're going to have a strong character, and you're going to be tougher, and you're going to be a better person. Sure, I mean, you can apply that to yourself, but when the patient has a fracture, and you should not be utilizing this, you will be a better person for having more pain, is not a clinically applicable quote. So pain is character building. To a certain extent, it may be true, but as a care provider, this is not our job to build character for the patients or the kids that you see. So this is not an applicable quote. No pain, no gain. So Arnold Schwarzenegger is very famous for this. Sure, and when you're working out and bulking up, sure. But when you have a broken bone, I wonder if you would say no pain, no gain when he has a fractured femur. So no pain, no gain is a very utilized in many social aspects or ethics or other personal growth issues, but applying this into a clinical setting is not advisable. So those were some of the things that the beliefs, some of that are out there, and I'm sure you've heard many of those, but those are all not applicable. What are some of the other provider barriers that we've identified in our study, in our project? Many of the providers that are out there, pre-hospital providers, they are doubting, at least they're questioning the need for pain management because they don't know the outcomes and they don't have the absolute data to really support the pain management. So we are going to address those as well. And then lack of education about pain physiology and pharmacology. So what does pain really do and how does it occur? That's not really taught in integrated fashion. And the pharmacology of pain medications that we give and what does it do and how long does it last, one of the side effects, are not fully taught. And they are really looking for this education to really learn about the pain physiology and pharmacology as well. And the most difficult thing that we address in pain management is assessment. There is no tool that you could just put on somebody's forehead and it shows a number of pain score. It just does not exist. Because pain is such a subjective condition, you have to utilize the patient's subjective scoring. So especially in pediatric patients too, their behavior to pain may be completely different than adults. So it's really difficult to utilize any tools to assess pain. However, there are some pediatric friendly tools that are available, such as FACES scale or Wong-Baker scale. I will go through a few of those here, but there are tools available that will help you assess pain better. And also, when we have a tool, the providers often question the validity and reliability of the tools, meaning they don't read the research papers to see what are the specific specificity and sensitivity of these tools. However, I reassure you, they have done all the studies they can to say these tools do work, and they're as close as you'll be able to come utilizing these tools to assess pain. And then the negative incentives of giving pain medications or the opioids include, at the time when we were doing the research, they needed an IV to give morphine. So the time and the effort to start an IV was a very difficult task. And at the same time, that increased the transport time. And that includes a workload because you have to document an opioid use documentation. And then you would take the patient to the hospital with opioid on board at the time. There was significant negative feedback from the ED physicians giving, why the heck did you give pain medication to my patient now? I cannot assess this patient. So these are all these negative feedbacks that the providers perceived that prevented them from freely utilizing the opportunity to give pain medications for patients who are in need of pain management. So those are the provider barriers, and the system barriers are following. So the lack of education in physiology, assessment, pharmacokinetics of the medications, and we really have failed in providing the outcomes data to the providers out there, pre-hospital providers, that your pain management does improve patient care and actually does improve patients' outcomes. So that data has not been provided, and hopefully we can provide some of those for you today. And then the medical control too. So when you call in for online medical control and then you request for pain medications, and because of online medical control is not seeing the patients, they have been very reluctant to allow for pain medications to be utilized. So therefore, now that the online, instead of calling online control for pain meds, and now it's into the protocol. So a lot of the EMS agency has moved to protocol-driven pain management. And then there are these multiple tiered systems, whereas first responder versus EMT versus paramedic. So when you are an EMT, has no scope of practice for pain management, such as narcotics. So when you pick up a patient, do you bother the paramedics for intercept? You're taking another agency out of the workflow. It just creates a lot more. We'll just take the patient to the hospital. So those were the limitations in which having multiple tier system, having intercept, sometimes it's counter benefit to the systems. So they were reluctant to call for intercept to give pain medications. Instead, they would just take the patient to the hospital without the benefit of pain medication. So these were systems barriers that we have identified. And lastly, that we've also identified some patient barriers. So some studies show that patients coming to the emergency department, fully knowing that they're in pain, they have not provided themselves with Tylenol, ibuprofen, meaning they have not helped themselves for relieving pain because they felt that the pain medications were harmful, and it is not their responsibility, but the hospital's responsibility, and they didn't have any available. So if the patients are not responsible for their pain management for themselves, why should the EMS provider should be? And then also 70% of the patients in the emergency department in severe pain did not ask for pain medications because of the subjective understanding of pain management, and they themselves felt it was inappropriate to ask for pain medication. So these are the patient barriers. So there are many different barriers that really gets in the pain management. So some of the interventions that have been provided since these data shows that protocol liberalization, meaning online to offline administration of morphine, actually did increase significantly from 2.8 to 19% in one study. And then having intensive education on pain management did improve pain management significantly, at least in this article published by French et al. Pain medication use went from 20 to 24. Non-pharmacological intervention went from 2.5 to 34%. And I'll go talk about non-pharmacological intervention a little bit. And the pain scores, obtaining pain scores went from 44% to 95%. So there's a significant jump from just 3 hours of education. So our Milwaukee Pre-Hospital Pain Management Group, we set out to impact an educational module on pre-hospital pain management, and this was funded through the EMSC Targeted Issues Grant. And we called this project called Pain Assessment and Management for Pre-Hospital Pediatric Emergencies, or PAMPER. So we're going to talk about some of the negative effects of untreated pain. This is just to answer this question, why is pre-hospital pain important? Untreated pain or persistent pain beyond the initial phase. So pain is a survival mechanism for all of us. So if we burn our finger on a stove, we will pull our fingers back so it doesn't burn continuously. So that instant moment you've learned that putting your finger in fire burns. But beyond that, does it help you to be having continued pain? So that's the problem we're dealing with. So if you have continued ongoing pain after that beyond initial phase, you're going to have increased metabolic rate. And actually, if you have a persistent pain that is severe, you are going to have problems with clotting. And it also alters your immune functions, meaning having some worse outcome than you would. And then emotional stress and suffering is another thing. So if you're continually having pain, the fear and anxiety of how long am I going to have this pain? Am I going to get any relief for this pain? These are the anxiety that actually does negatively impact your recovery. And the feeling of powerlessness and the feeling of loss of control even further creates another big black hole for these patients, and they're emotionally very stressed and they do suffer. So by having the patients having relatively, I wouldn't say pain-free, but manageable degree of pain would be the best ideal situation for these patients having pain. So what happens when you're in a lot of pain? You decide to fight, or you flight, or you freeze. And then afterwards, you have a lot of stress, anxiety, and tension, all this. So these are all the different effects of when somebody's experiencing pain. So what happens is the pain results in your stress response, and biochemically, stress hormones gets released that include epinephrine, norepinephrine, steroids, etc. So what this does is increase your metabolic rate. In some patients, especially fragile, small, young infants, and patients with significant special care needs, these metabolic rate increase may jeopardize their physical stability. So continued pain is not going to serve them any good. So having assessment tools to be able to monitor these kids and providing comfort will be very beneficial to not only these patients, but any other patients. Physiologic effects of pain is tachycardia, tachypnea, blood pressure elevations. If the patients have any significant cardiac issues, respiratory issues, any other hypertension or any other problem, this will be of a negative effect. And then behaviorally, patients will exhibit facial grimace, physical withdrawal, and kicking and crying during the initial phase of the painful event. But given all those findings, everybody reacts differently to pain. So you need to really understand and respect the patient's ability to deal with pain. So if you take a patient with who has never experienced pain versus sickle cell patients versus I'm going to use an example of Amish community where their level of pain tolerance is extremely high. I've had a 7-year-old kid who was run over by a trolley with a femur fracture coming in to ED saying, well, doctor, thank you for your visit and I thank you for taking care of me. And his femur was in a 90-degree angle, an excruciating degree. I was in more pain than this patient was. So every patient experiences pain differently. So I think you need to deal with that, at least given the subjective understanding how they react. So opioid does decrease the stress response. So in patients beyond the acute phase, providing opioid does decrease the stress response. So what happens is that they've done studies back in 1980s taking a neonatal patient as a model. So at the time when the patients are born, when they're undergoing surgery at the time, they didn't think patients felt pain, so they actually would go through surgery without pain medications. Very, very surprising. But this is only about 3-4 decades ago. So they would put these little babies under surgery, under knife, without pain medications. And lo and behold, they would have significant physiologic instability, have a pretty significant bad outcomes with these patients. And then they studied, they have significant increase in stress hormones, and they started giving pain medications, fentanyl and morphine, etc., and they saw a significantly improved outcome, and patient has significantly decrease in pain response. So so these stress responses that happen in these little babies do affect patients in a negative fashion. So they come to a senses that little babies, it's unethical to withhold pain medication for babies. So not only the acute pain, but one episode of painful episode, meaning a shot or circumcision, has a significant effect as well. So patients underwent circumcisions when they're a baby. Does that have any lasting effect or not? So what happened was Dr. Taddeo took all these babies who underwent circumcision and compared the boys who did not undergo circumcision. So what she found was that at 4 to 6 months old vaccination visits, they found the patients who went circumcision had significantly exaggerated pain response compared to those babies who didn't get circumcision. So at least that she felt that patient underwent the initial painful procedure from circumcision has different pain response, more exaggerated pain response than the babies who didn't go circumcision. So meaning you do remember that pain and you do respond differently even 4 to 6 months later. And then the other is that Dr. Weissman is an oncologist over in Milwaukee who is an oncologist who's giving diagnosing patients with leukemia initially. So during leukemia diagnosis, you do a spinal tap to diagnose if there's any leukemia in your spinal cord. So during this procedure, he randomized the patients to having some pain medications versus no pain medications. So when he followed these patients and then gave pain medications to a subsequent spinal tap procedures, he found that patients who did not get pain medicine the first spinal tap continue to have a very high pain response to spinal taps despite getting pain medication. So patients who have pain experience that is not is painful, it's not curtailed, it's not controlled, they will carry on the memory of the initial experience down the line and having significant pain response. So these are evidence to suggest that the patient's pain, acute pain, does impact them down the stretch and will be a negative experience for them. Why is pre-hospital pain management important? So what it does decrease the pain in patients' suffering, and it does provide significant comfort during transport. So, I mean, I personally have been in the back of the rig where it's very rockety. If the patient has broken femur or broken any bone for that matter, that jarring and significant discomfort. So it really provides comfort during transport and really does expedite evaluation and intervention in the emergency department, and we really feel that it'll improve patients' outcome. What are the most appropriate pain scales for pediatric patients? So this is called Revised Pain Scale, and this looks very odd, and a lot of people don't like these faces because they're not very friendly, but this scale is the most studied and most accepted. So this is called Modified Faces Scale. So it goes from 0, 2, 4, 6, 8, 10. And there's a script that goes along with it. It goes, these faces show how much something can hurt. This face shows no pain on the left. This face shows more and more pain, and this pain shows significant pain. So point to the pain faces that corresponds to your level of pain. So this has been studied and studied, is really effective, and this is paying a lot of patients to use the most. So this is the best pain assessment tool for kids between 4 to 16 years of age. So in your approach to pediatric, approach to any patients with pain for that matter, obviously the ABCDE, airway, breathing, circulation, and disability and environment is the first evaluation, and then you go to non-pharmacologic interventions for pain, and then you go through pharmacologic interventions. So given that non-pharmacologic, it should be applied for everybody, and we're going to go through this in a little bit. So what are some of the things that we can do without giving pain medication is to rest, meaning if the patient's moving about, to provide immobilization, and then apply ice and compression, elevate, and splinting, and dressing and positioning. So these may be all a patient may need. If you're able to provide these non-pharmacologic interventions, if the patient is comfortable, then your job is done, meaning you don't need to address pain anymore, but you need to continue to reassess. And some of the things that you can do non-pharmacologically beyond the things that I mentioned is to talk to the patient. So some of the methods that I have is that by talking is cheap. It doesn't cost much. If you talk to the patient, what do you talk about? Do you talk about school? Do you talk about video games? Do you talk about Barney? I don't know those of you remember Barney, but the purple dinosaur. So talking is cheap. So you should be talking to the patients to distract them from experiencing this significant distressful pain that they have. By distracting, utilizing toys, books, music, talking. Some providers that I know, they sing when they're taking care of pediatric patients, and they have toys. And we have, Wisconsin EMSC has a comfort kit in a bag full of all the goodies that we have. We have bubbles, books, toys that really light up. So these are things that you can use to distract patients during. So what this will do is it will really keep you from having to give pain medications. And the other thing that is very important is that having parents available and present in the rig if you can with the patient so they could be comforted. And having patients near them has been one of the most helpful things for the patients, researchers have shown. And the other interesting thing is providing the patient with a certain degree of control. So examples of this would be if you're starting an IV on a patient, you would ask the patient, do you want to do this in your left arm versus your right arm? Or do you want to do this in your wrist or your elbow area? So having the patient a certain degree of control really gives them the sense of ownership and they don't feel so much lost control. So having this patient control is helpful, and allowing that will be really helping you to take care of the patient. And using imagery, being at a beach versus being in an amusement park. So these are all the other imagery things you can do to just distract the patient. And then what I usually recommend about telling the truth is this. A lot of people say, what is the truth about starting an IV, and what is the truth about having needle pricks? That is being honest. Will this needle hurt? And the honest truth is you don't know. That is, you explain to the patient that some patients do feel a little bit of pain and some patients don't. So that's the truth. So you don't, but you say, if you tell a patient it's going to hurt and the patient is going to feel pain. If you tell the patient it's not going to hurt, and if they do feel pain, you've just lied to them. So what you leave at is that you tell the patient, I don't know exactly what you're going to feel, but some patients told me it's going to hurt, it hurt, and some patients told me it didn't. So it's up to you to experience so that's the simple truth. So really telling the truth does not mean it's going to hurt, it's not going to hurt, but leaving the experience for the patient to experience. And the last is explaining what's going to happen. So a lot of the patients undergo evaluations, they don't know what's going to come and they don't know what's going to happen. So a lot of the ED patients don't know what's next. So explaining what's going to happen, explaining that you're going to take the patient, put the splint under their arm, wrap it up, and go into the ambulance, and then do vital signs and do other assessments, and we're going to ride to the hospital and they'll take care of you. Explaining these step by step will really make the patient at ease and the parents as well. All right, so when these non-pharmacological intervention is not enough, then what do you do? Then you reassess the patient and make sure the patient still isn't in moderate to severe enough pain. If moderate to severe, meaning pain score is 4 or higher, then you continue to assess for any other pain medication needs. So fentanyl is currently being the most commonly used pain medication, and there are some more medications that may be utilized, but depending on your agency's protocol. A lot of the services are now carrying acetaminophen and ibuprofen. Those could be given. I've sort of surveyed to see how many of these are being utilized, and I haven't really had a lot of patients being given acetaminophen, ibuprofen from the EMS. I think this was to keep the patients from getting narcotics. But the patients with persistent moderate to severe pain, I think with fractures, with burns, I think deserve intervention. Beyond non-pharmacologic intervention is the fentanyl. Our dose, our use in our emergency department is 1.5 mics per kilo, but I have a red star here making sure that you abide by your own protocol. If it's intranasal, we use 1.5 mics per kilo. If it's with a maximum of 100 mics, and then if it's given IV, we use a little less, 1 mic per kilo, with IM or IV. And ketamine is another very interesting drug that sometimes is used in the field with concerns of potential side effects. But I think this needs to be used case by case and with your protocol. So you may need an online medical control to allow for this ketamine to be given. But I think fentanyl is in most of the paramedic services to be able to given offline. So briefly about intranasal fentanyl, I'm sure you're very familiar with this. Dose is about 1.5. It really starts working within 3 to 5 minutes, and it does only last about half an hour to an hour. So by the time, if you're not too far from the destination, this should be enough. But as you know, patients' pain experience is subjective. So within 10-15 minutes, if the patient requires more, you can give another dose. So all based on your protocol, but we allow our paramedics to be able to give a second dose without having to call in. The effect of intranasal versus IV fentanyl, as you see here. So intranasal, IV actually does work pretty fast. It's probably within a minute or two, but the intranasal versus does work within 5 minutes or so. So it's a fairly equivalent efficacy in pain management, but the onset is slightly slow. So having an IV placed in a patient actually will require time. So giving intranasal actually will end up being equal, if anything, for the pain management. We talked about fentanyl. So what I would recommend in any patient with experiencing significant pain, assessment of the pain using 0 to 10 facial scale, and the intervention, every patient should get non-pharmacologic intervention using RICE as well as other distraction methods. If the patient is persistently over 4, then you will consider giving fentanyl, intranasal, or an IV, and they may repeat every 10 to 15 minutes up to twice, and make sure that patient's cardiovascular status is stable, and in children especially, systolic blood pressure is over 80. And then if you need further doses, I would recommend calling online control for additional dosing recommendations. So what happens when you bring the patient to the emergency department? So here's what's very interesting. So if you don't provide pain medications in the hospital, so a patient comes to ED, and it takes time for us to evaluate the patient. Then we order pain medications, and then we get the radiograph to figure out what's injured. Surprisingly, the time that it takes for initial evaluation and the time it takes to order pain medications and for nurses to pull it and to give it, this could be anywhere between 10-15 minutes to an hour. Evidence-based, the study that I've cited earlier, in some places it's up to 2 hours. So I think that could be a pretty significant issue in patients who are in pain. So getting to the bottom of it, it just delays things quite a bit. If the patient already has obtained pain medications in the field, they come in, they get seen by a doctor, they get x-rays. So this is not, I'm not saying this happens all the time, but if the patient is comfortable in the ED after receiving payments in the field, it really expedites the care in the emergency department. So we can get those radiographs done to diagnose the patient. So patient comfort comes first and early if you give pain medication. And if the patient is comfortable, it really helps us take care of the patient with increased efficiency and get to the bottom of it quicker than if they are not controlled. Then what are some of the issues with pain management, giving pain medication? What about patients with head injury? I mean, there's some arguments with this too. So if the patient's altered, can you give pain medications? Yeah, so I would argue that if the patient has head injury and patient has is in a lot of pain, his blood pressure is high, and intracranial injury, if you have a high blood pressure, I think that would work adversely in intracranial injury. You would have increased swelling. So I could make an argument if the patient is in a lot of pain, has a potential head injury, their blood pressure should be lowered. And then you don't want to cause a lot of further injury into the head. So provided that if you don't have sufficient blood pressure, you should not be giving fentanyl or morphine for these patients. But head injury is another controversial issue that we don't have clear answers for. If you're unable to obtain vital signs in pediatric patients because they're fussy, they're moving about, so what do you do then? If the patient is pink, has a palpable pulses, and heart rate is reasonably obtained, if the patient's in a lot of pain, you're not able to get vital signs because they're in pain. So I think those cases you can make an argument to give pain medication as well. In prolonged transports, if you need more doses, then you should be able to provide those with online control guidance. And then the role of accepting MD and medical control is that it all depends on your level of transport, and it all depends on the factors of additional doses too. So make sure you call in your online medical control for additional doses if you are traveling far. Now, what about the emergency department viewing this pre-hospital pain management? So we all need to be aware of your guidelines and your protocols, so we are familiar with them and be able to provide you guidance, and so we don't adversely give you recommendations that goes against your protocol. And then confidence in EMS providers, meaning we need to trust our EMS providers that they are doing the right things, and there shouldn't be any criticism, openly at least. If there's any issues, that should be done through the QA issue. And then have a voice in our EMS system, meaning ED providers who should have voice in the EMS system, and then we should be really advocating for patients' care. And then continuum pain. So whatever happens in the pre-hospital arena should continue in the emergency department and continue to happen within the hospital. So we all have a patient's comfort in mind, and better outcome and fast healing is our goal. So that's to cure sometimes and to relieve often and to comfort always is the motto that I use for taking care of patients with any complaints to the best of my ability. So if you keep this motto in your mind, I think it'll be a lot clearer for you to be able to do what you need to do in the pre-hospital arena. So that's a little tidbit of pain management historically and what I've researched and what I have for you. So this is not a new knowledge, but it kind of gives you a sense of how pain management has come over the last 20 to 30 years. And then the opioid epidemic has really hit hard, and what we do in the field. But that is for patients who are seeking drugs, having chronic pain, but patients with acute pain management issues such as fractures and burns, that should not be an issue in taking care of patients. So with that said, if there are any questions, please send them to me, myself, or Mitch. Then we'll thank you. Have a great day. Maybe we'll see you next time.